Dr. Sameer Trivedi, Dr. Himanshu Pandey, Dr. Bal Chandra Kashyapi, Dr. Gautam Ram Chaudhary, and Dr. Deepak Rajyaguru.
So with the permission from the chairs, I'll continue. So we were at level 2 only, but we had completed the right-sided ones and we were on the left-sided tumors. The left-sided tumors are more tricky, and in addition to clamping the right renal vein, almost always you will also need to clamp the right renal artery, because otherwise there would be an inflow that will continue and the whole field will become bloody because of the ooze that will come either from the adrenal or from the retroperitoneum. There is an alternate technique which I have put in red, and that is of cross-clamping the infrarenal aorta and obliquely cross-clamping IVC, sparing both the right renal artery and the vein. But that will depend upon the exact location of the thrombus, whether such an oblique cross-clamping is possible or not. But if the infrarenal aorta is cross-clamped, one can easily cross-clamp it for 30 minutes, because that will lead to ischemia only of the lower limbs, and lower limbs can tolerate ischemia easily for 30 minutes plus, warm ischemia. So these are the key steps of clamping for the left side. I haven't shown the aortic cross clamp picture. So this is a patient who had a level 2 right-sided.
No.
This lady was operated by a thoracoabdominal approach because she had a huge tumor, and we had to keep the tumor out before we could get an exposure of the IVC. So here you can see that the kidney has been removed just to get an exposure of the IVC and for further dissection of the IVC. So there is an umbilical tape above, there is an umbilical tape on
First,
the
we will do this. I will cinch down.
tumor. And
second,
there's a big bulge in the infrarenal IVC.
In the lock. You know what I mean?
And as I told you that the lumbar veins, they can trouble a lot. So we need to control the lumbar veins.
Down, okay?
Because once we make the vena cavotomy, there would be a significant gush of blood from the lumbar vein. So now we are replacing the umbilical tape with the Setinsky clamps. And you can see that although everything is clamped, but there is a reasonable amount of gush of blood that is going on.
I might need one more of those white.
And now once the tumor is out, this gush of blood comes down. This is freshening of the wall. So superior clamp has been released temporarily because there was a suspicion that there is perhaps something remaining superiorly, but once it has been confirmed that there is nothing remaining superiorly, this is the closure of the IVC. Again, as I mentioned, with either a 50 or a 60 proline. So if it is a level 3 thrombus, which is intrahepatic, but there is a good gap between the hepatic veins and the superior limit of the thrombus.
Hold the needle.
One can carry out an intrahepatic dissection of the IVC because there is a well-defined plane between the IVC and the hepatic parenchyma. The important thing is that the tributaries from the liver, they drain into the anterior and lateral surface of the IVC. They will never drain into the posterior surface of the IVC. And therefore, this intrahepatic dissection of the IVC is possible almost to the hepatic veins. And once you dissect and reach the upper level of the thrombus, and there is enough space for you to put a cross clamp above the thrombus, then the subsequent steps become like an infrahepatic thrombus. So this is a patient who has an intrahepatic thrombus with a large tumor.
Suction karo,
and this is what is the ultrasonogram. As I mentioned, that you measure the exact distance between the point where the hepatic veins are opening into the IVC and the superior limit of the thrombus. And if there is an approximately 2 centimeter gap, then you can carry out an intrahepatic dissection.
It didn't get completely cinched.
So this is the video showing the intrahepatic dissection. Again, this patient has a huge kidney, huge tumor. So after the nephrectomy, you can see that now this right kidney is hanging on the IVC. There is enough space. Now this is the intrahepatic dissection of the IVC. You will find tributaries from the hepatic parenchyma into the anterior and lateral surface of the IVC, but not into the posterior surface of the IVC. Slowly and steadily, if you keep on ligating these tributaries, then you can reach the upper level of the thrombus and you can put a cross clamp there. You'll find a number of these tributaries, but my personal preference is to ligate with a 3-0 or a 4-0 silk. I don't like to use clips because these clips can slip, because we are continuing to dissect in that area and we are continuing to manipulate, and if any one clip slips, then the whole field will become bloody and it will become difficult for you to identify that bleeder and control it. And obviously the assistant plays a major role. So here you can see the extent to which you can dissect the IVC within the liver parenchyma, and then you can put the cross clamps. The sequence in which you put the cross clamps are the opposite renal vein first, the infrahepatic, the inferior part of the IVC next, and then the superior part. So here you can see that there has been a dissection and the tumor is hanging on the IVC. So you can put the inferior clamps first, any of these two, and then the superior clamp is put right in the end. And they are opened also in the same sequence, not in the opposite sequence. And again, as I mentioned, the vena cavotomy should be kept as small as is feasible to just wriggle out the thrombus. Because if you make a bigger vena cavotomy, then obviously you will take more time suturing it. And if the wall is not infiltrated, then it doesn't matter. But if the wall is infiltrated, then that part of the IVC needs to be sacrificed.
So it leaks on top of the thing.
Here, because the lumbar veins have also been taken care of, so once the thrombus would be delivered, there would be hardly any bleeding. Whereas if the lumbar veins are not ligated, which is usually what happens, then you have to quickly close up the vena cavotomy, otherwise there would be some continuing blood loss. Okay, so now we go on to the next one. So if the level is higher, then you have to completely mobilize the liver, and we take the help of GI surgeons. And this is what is described as the hepatic transplant technique of Ciancio from Miami, Florida, where you completely mobilize the liver, the ligamentum teres, the falciform ligament and the triangular ligaments, and control the IVC above the hepatic veins. And you also have to cross clamp the IVC below the thrombus, opposite renal vein, and Pringle's cross clamp of the portal structures. That is also absolutely essential, otherwise there would be hepatic congestion and a lot of bleeding. If there is a distal bland thrombus, then theoretically we have two options. One option is to take the thrombus out, and the other thrombus is to ligate the IVC below. The practical option is only to ligate the IVC below, because if you take the thrombus out, the thrombus will reform almost on the table, if not on the table, in the post-operative period, and there would be a very high incidence of suprahepatic control, cross-clamping of the Pringle, and ligation of the IVC below, and excision of the IVC for a right-sided tumor where the left renal vein and its tributaries are saved, but the IVC from the hepatic level to below the hepatic level is excised.
Dr. Sheth,
Yes.
I'll request you to be interrupted for a minute. There is a retroperitoneoscopic partial going on there. We'll briefly go to Dr. Pranjal Modi's theatre and then come back to you, sir.
Okay.
Sorry for the interruption.
No problem, no problem.
You
cannot
also included?
But you cannot interrupt the IVC for a long time.
Yeah, thank you.
So,
Could you switch? Yeah. Yeah, please go ahead with the history. Dr. Pranjal, we are with you.
I am presenting a case of 65-year male patient presented with complaint of lap flank pain since 15 days.
Looks very
Patient is hypertensive since 12 years. Patient has no any other medical comorbidity or surgical history. On all investigation,
Where are
including
instrument
routine,
basis available?
complete blood count and renal function tests are normal. Ultrasonography, left kidney having 40 by 40 mm size, solid hyperechoic lesion at upper pole of the left kidney, and raised USG findings are normal. On CT IVP, there is a 40 by 40 mm well-defined heterogeneous enhancing mass lesion that is present in upper pole, and lesion having no extrarenal invasion with surrounding fat planes are well preserved. The lesion does not cause any encroachment over the adjacent renal calycis or pelvic calyceal system, and the findings are suggestive of malignant etiology, possibility of renal cell carcinoma. Rest findings including suprarenal gland, left renal vein, left renal arteries are normal. Here is the CT images showing 40 by 40 mm mass lesion in upper pole of left kidney with no extrarenal invasion. Another image showing upper pole lesion. So final diagnosis is left renal mass, primary 40 by 40 mm, upper pole, and the stage is T1A N0 M0 with hypertension. And the plan is laparoscopic left axial nephrectomy by Dr. Pranjal Modi, sir.
Welcome, Dr. Pranjal.
Yes, hello.
We've been watching you, sir.
Yeah, so just we have approached from retroperitoneoscopic approach. Reason is the tumor is posteriorly located in a CT. It's a upper polar tumor. It's easy to deal with from the retroperitoneal aspect, and you can see the left side. If I see remember the CT correctly, then probably there is an early division of the artery. So I would like to find out both the division of the artery very early, and I think the straightforward approach will be again the retroperitoneal. So within 5 to 10 minutes, usually we find out the artery and the vein in most of the cases. So it's very quick.
The tumor is on the anterior side.
Tumor is on the posterior side.
No, in case if the tumor is on the anterior side,
Yes.
still you opt for the retroperitoneoscopic approach or?
Well, transperitoneal is preferable because otherwise I have to flip the kidney and to do the rest of the surgery. Here the surgery is easy if it is a posterior tumor. Retroperitoneoscopic approach is preferred.
Yeah, port location of the ports, can you just?
Yeah, just I'll show you from external view. It's same as any nephrectomy, simple nephrectomy, radical nephrectomy, donor nephrectomy, the port placement is same. I'll show you. Garam pani. મગજ ગરમ થાય એટલું પાણી ગરમ હોવું જોઈએ. Huh? Yeah. So you are showing it from external. So you show from behind, right? Or else I can show it from here, right? So you can see the iliac crest is marked over here, and the excess port is at the tip of the 12th rib, and I think behind it there is a one port, it's roughly 3 fingerprint behind. There is a port which is going to be useful for the suturing, passing of the needles and sutures through this port, and this is a 5 mm working port. So all bulldog and everything will go from the posterior port because it is a straight, it's exactly perpendicular to the artery, and
Where is the head end of the patient?
so head end of the patient is to the, you can, just a minute, my camera is rotated here, yes.
Dr. Pranjal, we have an external camera showing it.
Okay, fair enough. So you can show
Watching the external image.
you can show the head of the head end. external camera. So you can show the head end. Head end is, yes, that's the head end. Yes, right? So I am proceeding again with the surgery.
Reverse.
Pneumo is gone. Suction was on, I think. Yes. Okay. So now, once we identify the artery, go close. What is the pneumo pressure? Pressure is 15. It doesn't. No, it doesn't look like it's 15 right now. Everything is falling. Go in, close. No, there is no pressure. Pneumo. Just check the pneumo. No, there is no pneumo. We have lost the gas. નહીં ત્યાંથી તકલીફ નથી તકલીફ કદાચ સિલિન્ડર ખલાસ થઈ ગયો છે એવું છે જો તો
I'll request Dr. Sheth. Sir, please come, sir. Yeah.
Okay, so this video shows the suprahepatic IVC dissection. You can see the liver is being pulled down and all the ligaments have been taken care of, and these are the connections between the suprahepatic IVC and the diaphragm. There will be some small veins but mainly fibrotic tissue, and this is the GI team. They are quite comfortable dissecting the suprahepatic IVC. This is a test clamp being put, and then this would be put again later on. So once all the clamps are put, then you can either open up the IVC and take the tumor out, or the other option is you can dissect the IVC within the liver as was shown, but once these cross clamps are there, then dissection becomes relatively easy because the liver shrinks. So in this particular case, after putting all the clamps, the intrahepatic IVC was dissected because there was a big tumor there, and we needed to resect the IVC also because there was an infiltration of the wall. So this is the wall of the IVC that is being excised, and we had to excise a good part of the IVC wall, and the left renal vein was left along with the tributaries. And there was a bland thrombus in the IVC below. So the superior, this is the suturing of the superior part of the IVC deep up in the hilum of the liver. This is the hilum of the liver where the remaining part of the IVC is being sutured. And the left renal vein had a small communication with the IVC above, but it was draining mainly through the tributaries, and the lower part of the IVC had to be cross-sutured and occluded because of the bland thrombus. So if there is an intra-pericardial extension, then for right side, either you can use a thoracoabdominal approach, and the cardiac surgeons, they can quite easily control the IVC putting in a finger after opening up the pericardium. But for a left-sided tumor, one needs a long midline laparotomy and a mid-sternotomy, as was done for this particular case. The superior extent was even above the hepatic veins and a left-sided tumor. So we had done this case by a long midline laparotomy and a mid-sternotomy, and this is the specimen that we got. For a higher level thrombus, the initial technique that was described was cold hypothermic circulatory arrest with exsanguination, which meant that the patient is put on cardiopulmonary bypass and then cooled to a temperature of 18 to 20 degrees centigrade, and then the patient is exsanguinated. Exsanguinated means that the arterial inflow is stopped, the venous outflow continues, and the patient is exsanguinated, and after that, the heart-lung machine is stopped, which means that the patient has a hypothermic circulatory arrest with exsanguination. And there was a good degree of mortality with that procedure. We have described a technique where we cool the patient to a temperature of 31 to 32 degrees centigrade after putting the patient on cardiopulmonary bypass. But instead of deep hypothermic circulatory arrest, we have mild hypothermic partial circulatory arrest, which is cross-clamping of the supraciliac aorta, which means that there is a preservation of the blood supply to the central nervous system, to the coronary system, bronchial, and the upper limb vasculature. Of all these, the blood supply to the CNS is most critical, and second most critical is continuation of blood supply to the coronary vessels. So in this patient, a left-sided radical nephrectomy has been done, and there is a thrombus which is going up till the atrium. The lower part of the IVC is soft. The left renal stump is there. Now this is the cardiac surgery team. They have done a mid-sternotomy, and this is the supraciliac control of the aorta. The aorta can be easily identified between the crura of the diaphragm, and once the crura are split or separated, then the supraciliac aorta, this is the patient being put on cardiopulmonary bypass with one cannula going in the SVC and one cannula going in the IVC below the thrombus. So after the patient is put on bypass and cooled to a temperature of 31, 32, and the supraciliac aorta has been cross-clamped, this is the IVC being opened, and there would be some bleeding, but only one sucker in the IVC is adequate, which is a pump sucker which goes into the bypass machine, and then you can see that it's a relatively bloodless field. It's not as bloody. It's not totally bloodless, but it's a reasonably bloodless field. And this is the thrombus being pulled out from the right atrium. And this is the sucker which has been put from below, which has come up into the right atrium. This is the gauze piece that is being pushed from the right atrium, and it will be retrieved from the IVC below. So once the entire thrombus has been taken out, that was the closure of the right atrium, this is the closure of the IVC, and this is the reversal of the cardiopulmonary bypass. These are a few of our publications, and our total experience is now more than 100 cases, where we have done level 4 thrombus in 23 cases. Most of our cases are actually a higher level thrombus, but we do get lower level thrombus patients also. And we have divided, in the publication, we have divided them into group 1, which is level 1, level 2, and group 2, which is level 2, level 3. The mortality, we have had 5 patients whom we lost in the group 3 and 1 in group 1, and the other complications, they have all been described in the publication. Thank you very much.
Thank you, sir. That was excellent. And we are sorry for repeated interruptions because of the live surgical workshop.
Yeah, that is the advantage of semi-live. One can stop anytime. So,
just a small query, sir.
Yes, please.
Do you use Fogarty or a Foley's catheter to flush out or to suck out any small debris of the tumor thrombus?
No. One can get a good exposure, open it up, and one can flush it. One can use normal saline for flushing, etc., etc. There are no blind areas. So you don't need to use a Fogarty or a Foley's catheter for that.
Even preoperative embolization.
Preoperative embolization, yes, for left-sided tumors, if you cannot approach the artery early. But for right-sided tumors, practically never. For left-sided tumors, you can look at the CT scan, and if you feel that there is a bunch of collaterals surrounding the vein, surrounding the artery, and you may not be able to reach the artery early, then in that situation, it is a good idea to embolize. And what we do is we embolize on the morning rather than one day before. because then the patient does not have that tumor embolization syndrome. But then one has to talk to the radiologist and be very certain what is the exact agent they are going to use. Because once what happened was, we asked them to embolize, they so-called embolized, and on the table we realized that everything was bloody, and we reached the artery in the end, and then we realized the artery was pulsating, and then we talked to the radiologist. He said, I was too scared because whatever I was putting in, it was getting flushed away. So that also one will have to talk to the radiologist and discuss and what particular agent that person is going to use and how that particular patient's artery is going to get embolized.
Dr. Seth?
Yes.
Here, sir.
Yes.
So where have you found, if you have used veno-venous bypass helpful in level 3?
We have not used veno-venous bypass. We have not used it, but it has been described in the literature, but we do full cardiopulmonary bypass rather than veno-venous bypass.
And sir, usefulness of TE, transesophageal echo.
Yes, it is quite useful. It is quite useful. One can see the exact upper level. One can see where it is in the atrium. And before opening up the atrium and before opening up the IVC, one gets a complete mental picture what is the exact anatomy of that particular patient. TE is available in a cardiac surgery OT, and it is being used as a routine.
Yeah. And sometime while taking the thrombus out, surgeon feels that part of the thrombus is there or wall of the IVC was involved, then how to handle that situation?
The part of the IVC which is invaded has to be excised, and if the lumen comes down to even 1/3, that is acceptable. But if it is very narrow, then one has to use a patch of the pericardium. We have replaced the IVC with Dacron patch, with a Dacron tube also. But the problem with all these synthetic tubes is that they thrombose, they get occluded within about 6 months. But 6 months is also good enough time for collaterals to form. If they get occluded slowly, then usually, but we have used these Dacron tubes in patients with IVC tumors rather than IVC thrombi. Tumor thrombi, we have generally been able to excise and get away and reconstruct, but complete replacement has been done in 3 cases of IVC tumor, leiomyosarcoma of the IVC.
Thank you, sir.
Yeah, so regarding that transesophageal ultrasound, whatever anesthesists do, they'll put it along with, after the tube is put, they'll put it in. It's a continuous monitoring all throughout the procedure because you never know, as you're fiddling around, it may just, thrombus might just migrate. So just leave it inside and it is being monitored
yes,
continuously.
They keep on monitoring.
Sir, on that, regarding the tumor thrombus, the spillage, especially on the cardiothorax, they're not worried about the tumor spillage. And here also in the abdomen, when you open the IVC and tumor, how often you have seen the bed recurrence due to the spillage?
I don't think it occurs because once, it is very difficult to take the thrombus out intact, although that is what is described in the book. But so many times the thrombus will fragment. And after you have taken out the thrombus and if you have given a good wash and cleaned all the microscopic thing, and then the tumor bed, you can leave distilled water for about 10 minutes. At least we haven't felt that there has been a recurrence because of the tumor spillage. Yes, patients have had metastasis, patients have died, but perhaps not because of tumor spillage. Tumor spillage should lead to a disseminated intraperitoneal recurrence. That is not what has happened.
Sir, Amlesh, sir.
Yes.
Here, sir.
Okay.
So you have shown in large tumors, you have removed the tumor.
Yes.
And then you have dissected the IVC.
Yes.
How will you ensure that the tumor will not fly away?
You cannot be 100% certain, but you have to use a soft clamp and your manipulation of the IVC has to be minimal at that time. But yes, you are right. We have had 2 patients amongst these mortalities.
Embolism, pulmonary.
Embolism, yes. These 2 patients died on the table because of pulmonary thromboembolism, yes.
Sir, do you feel that histopathology of the tumor, they give us the consistency of the thrombus different, like a clear cell will be the solid one, easy to take out, papillary may not be that good, well-formed thrombus?
All thrombi, actually clear cell is also reasonably friable, it is yellowish. And in peanut also has, peanut has a relatively pinkish, again reasonably friable. If the tumor is infiltrating the wall, that is a tumor which will not be friable, but that will have a very poor prognosis because that tumor would be biologically aggressive.
Sir, is there any role of TKI, pre-op TKI?
Yes, there are studies which show that if you use TKI, but then the fact is that the response to TKI would be about 50%. So you are taking a 50% chance of tumor progression. And if the patient is borderline operable and you are trying to bring it to this side of the borderline, there is a 50% chance that the patient may actually go on the other side of the borderline and may not remain operable at all. Then you are going to lose the patient. So if you can operate even with a high risk, it is better to operate rather than give TKI and hope for a good response.
Can I ask a last question?
Yes, please.
You know, the one that we've done at just look many of these tumors, the cardiac surgeon has always tried to just press the IV thing, so try to remove just by pressing. Ultimately, he takes a small sponge on holder without the sponge, a thin one with the pediatric one, and he pushes that right through, and then we flush it, and he tries to take out the rest this way. And at the end of the day, there'll always be little bit of bleeding. It's never that there's no bleeding. How would you know that what he said was right, esophagus endoscopy, but if you don't have that, how do you know that, okay, everything is removed and there is less chance of pulmonary embolism?
Actually,
we had a patient who died of an embolism after we were sure we removed every bit of it. So how are you so sure of that? Even your transesophageal endoscopy, I mean your ultrasonography, will now be able to see those small things. That was a question answer asked. Thank you.
Thank you, sir. Thank you very much.
Thank you.
Just last, sir.
Wonderful, Dr. Malay's seeing you doing all this very challenging procedure. My latest experience in Sir Gangaram Hospital with 2 patients. There, of course, this liver transplant surgery team is very robust, and the cardiac surgery with their help. I found they were using a different technique. They were not opening the IVC right. We open exactly in the front. They rotate the liver towards the left side of the patient completely and open the IVC on the right side. So things were, I found, very easy to handle because you are afraid of even the lumbar vessel, which is posterior to the IVC near the left renal vein. It comes in your view, and suturing is also very easy because you are reflecting the liver on the other side. From in front, things are a little different and difficult. So this is just I wanted to share with you that next time you probably do that way, you will find a difference.
No, we also do exactly the same way. If you, in all the videos for the right-sided tumor, we have gone on the right side and made a vena cavotomy on the right side only. But the last video where they were mid vena cavotomy, that was actually a left-sided tumor, where there was a big tumor and left-sided tumor was taken out separately, and then the renal vein stump was delivered from left to right, and then the vena cavotomy was made in the midline. But for a right-sided tumor, in general, we do extend the renal vein, but that last video was different. For right-sided tumor, in general, it is better to make a circumscribing vena cavotomy and extend that to, that is what has been shown in the remaining videos.
Thank you, sir. Thank you very much.
Thank you.
Can we go to Dr. Pranjal Modi, sir? He's doing some interesting.
Pranjal, sir?
Yeah, I'm still struggling with the pneumo because the ports are leaking.
Oh, okay. Sir, in case there is a small rent in the peritoneum. Pranjal, sir? If there is a small rent in the peritoneum, would you continue as usual or would you convert to transperitoneal? How would you?
No, just we put a Veress needle or maybe 5 millimeter port into the peritoneum, so to provide the outlet to the accumulating gas in the peritoneum. So a small rent it doesn't matter much, but if it is a large rent, we would like to, yeah, it's difficult. When it is a large rent, it is definitely difficult situation. And sometime we try to cover it with the clip. I think there is a, I'm really suffering from the pneumoperitoneum related issue. There is no pneumo. The gas is leaking from all the pots. That's the problem. Pots are quality is so poor right now.
Yes. I think it is not leaking into the peritoneal cavity. The
No, no,
pores
no.
are
It is
leaking.
not leaking in the peritoneal cavity. I can see the hiss of, I can hear the hiss of gas coming out of the port. And that's the reason why we are facing a problem. We have changed so many things, but still the ports are not good. We changed the port also, but it is not good. Still the second port is also leaking a lot. So maybe एक काम करते हैं, मेरे को standard તમારે stores ના છે 10 reducer સાથેનો port હશે કોઈ બીજું?
Sir, will air seal help in this situation?
Pardon?
Air seal.
Air seal can help, definitely, but we don't have to, I mean, I don't have it here.
Have you ever used in
No, I have seen it only. I have not, no, I have not seen in even retroperitoneum. I have seen only in transperitoneal.
Right.
So why don't you apply some sort of gauge piece or something around
Give me that.
entry
આમાં
point?
પછી reducer નહીં હોય ને? આપો ને reducer સાથે આપો. ચલો, we'll fix it up. Less likely. એ reducer નહીં.
The retroperitoneum scope
rubber reducer.
We also do same school. It doesn't leak from outside. This is leaking with the plastic ports, and the rubber thing inside is not right. So putting copies outside won't help. It's not a laparoscopic port is leaking from outside. It's leaking from inside. They have to change. She's changing the port. So otherwise,
ફોન કરીને મંગાવી લો ને. Disposable 4 પોટ મંગાવી લો અહીંયા. એમાંથી કાંઈ તકલીફ પડે તો we can work it out. This is very bad. They're cheap ports, right? Really.
That is a right comment actually, cheap ports. What we are facing also nowadays. This is the problem. The surgery which will be done within 2
આમાંથી
hours.
leak થાય છે ને?
4 hours.
અહીંથી હતું. ના, એ ફિક્સ કરવા માટે નથી જોઈતું મારે અત્યારે. આને રાખી દો ને સિસ્ટર. એ આવે પછી જ નાખું ને, એમને એમ તો ક્યાં આપણે ઊભા જ રહ્યા છીએ અત્યારે અધરવાઇઝ. જે હું ઇન્સ્ટ્રુમેન્ટ નાખું છું ને સિસ્ટર, તમે બધું અડાડી દીધું સામે અહીંયા જુઓ. There is no pneumo. See? How can I work?
So we'll start with the next session. Although 30 minutes early, we'll ask the chairperson to continue so that we'll change the chairperson at 4:30 only. So next is on SRMs. Dr. Anuj, can you invite the speakers?
So we are starting with the next session on small renal masses. Our first topic is ablative options in SRM, Dr. Ankur Mittal and Dr. Vikas Panwar.
Good evening, everyone. And we are here, my colleague Dr. Vikas and myself, will be talking on SRM, ablative options. Since morning we are discussing so many, we have seen nephrectomy surgeries. The house is full of uro-oncologists. I just need the hands to be up. How many of us are using ablative options in treatment of SRM in the hall? So I can find maybe 5-6 hands are there. So there can be a number of reasons why we are not using it. One reason can be that the limitation of resources or limitation of availability or understanding. I think we all understand about it. So probably we will discuss today that what are different options, a brief overview, and definitely what exactly we need to know. We don't need to know much about ablative options, frankly speaking. So what SRM is, we understand that anything which is less than 4 centimeter. Oh, it's not displayed, sorry. Can we have the presentation on the screen?
Yes, sir, we are just on it.
So we are here today to know what are the most common type of ablative options, how they work, and how to choose one of them if it is available with us in our basket. And can we use that as an option based on current evidence?
surgeon is against using that alternative technique. That's why your slides are not there, you know, it is still the surgery.
Is it taking time?
Yes, sir, we can start.
Thank you. So I think we all understand about SRM, how to define it. We understand that how to select a therapy based on tumor characteristic, patient characteristic, and definitely renal function. We also understand that today in this era, NSS definitely is standard of care for this T1A disease. But yes, we also need to understand that these minimally invasive treatment, which we call ablative therapies, they are designed to destroy, and now they have a place in literature as well as for this T1A disease. And the established technique as of now are cryoablation and radiofrequency ablation. And the emerging techniques, we have microwave, we have high frequency intensity ultrasound, stereotactic radiotherapy. Maybe 10 years down the line, we say RCC is not meant for radiation. And definitely irreversible electroporation. If we go with guidelines, if we go, what we understand that this is mainly meant for fragile patients, the patient which we cannot operate. I think European guidelines are with us. But yes, if we see AUA and NCN, they say that this option is now a standard alternate option. Probably we should keep it as an option, alternate option, apart from NSS for these T1A lesions, and wherever feasible, if patient is fragile in T1B2. So these are the patient selection. We will understand that any patient, old age, fragile, poor performance status, numerous comorbidities, compromised renal function, high risk morbidities, and T1A, definitely we can have this, because when we need to discuss with patients, it is a shared informed decision making. So we cannot hide the other options also as a uro-oncologist, that we don't give them option, that what other options are available. Regarding the approach, whether it is percutaneous, laparoscopy, open or extracorporeal, there is all the studies they show similar overall survival and cancer-free survival. But yes, if we talk about AUA guidelines, they have supported percutaneous over other approaches because of less morbidity and cost. Renal mass biopsy, yes, pre-procedure indicated in the guidelines, post-procedure still debatable whether it is necessary or not, as we all understand that 20% patients still can have benign lesions. Let us come to one by one. The most definitive is like, we have cryoablation. It is how it works, as the word suggests, it is, create intense cooling. So the tip of cryoprobe, argon gas is depressurized to have intense cooling. We need to have 2 freeze throw cycle, rapid freeze, slow thawing probably is the type what it works. Several probes need to be placed in the tumor to map it properly so that the area should be covered. And definitely it is how it is work, and require a supporting department help. It is not the uro-oncologist who will go and do it. He can definitely be a part of the team, but yes, you need a supportive department. Similarly, for radiofrequency ablation, RFA, definitely there are, it is through electric current into a tumor. The ions, they agitate, cause heat, and then goes till 69 degrees centigrade and denaturation of protein. And again, placing so many of probes, and the assessment is done by doing imaging. Microwave ablation refers to use of electromagnetic microwave. Vigorous movement of water molecules in the tissue causes increase in temperature. It is again based on heat based, and that is why the mechanism is different. That's why we say it can overcome the heat sink effect. We talk about HIFU, high intensity focus ultrasound. It is again a form of a thermal ablation. Ultrasound energy is focused on a small volume of tumor, causing movement and friction of cells. And yes, most important advantage is extracorporeal way of giving it. You don't need percutaneous, lap or open. You can use extracorporeal, but there are so many limitations as of now in literature about HIFU. It is not ready for clinical use as of now, because when the literature assesses that tissue damage, it is only 15-30% of tissue which was targeted, and the damaged tissue found only 15-30%, so the rest is left over, probably may have recurrence. Stereotactic radiotherapy, I think our colleagues will be presenting in the next talk. I will skip it for a while. We have a separate talk on this. Irreversible electroporation, it is disrupting the integrity of cell membrane through the formation of irreversible nanopores and causes cell death by inflammatory reaction. The mechanism is again on high voltage, and most important thing, probably it is evolving, it is a non-thermal ablation. This feature allows the ablation of tumors that are in close proximity to potential heat sink and vital structures where we call blood or urine, hilar tumors. So again, the most important criteria falls there. When we do a procedure, as a uro-oncologist, we also need to monitor it, whether we are really doing it appropriately apt. So I think CRA, cryoablation, is one of the techniques where we can monitor what we are doing. But rest of the procedures like RF and microwave, they cannot be monitored because they work on principle of heat. It is developing a thermal lesion. So this is a limitation of these procedures. If we talk about assessment, the RECIST criteria doesn't fall here. It is mainly when you do an imaging, you stop seeing those enhancing masses, you see the shrinkage of tumors, so probably absence of contrast media is the way you assess all these modalities of ablation. We here today, probably we need to take some message. By the end of this presentation, when we stop the presentation, we should be aware that if we talk about procedure timing, what we need to select among these. If you are worried about bleeding in these frail patients, uncorrected coagulopathy, what to select. If you are talking about the size of tumor, if it is more than 4 centimeter, if it is more than 3 centimeter, what to select. And definitely hilar tumors, what to select. So I think these answers are still unanswered in our presentation. My colleague Vikas will take over from here, and probably he will be discussing about the safety, efficacy and effectiveness, and we'll try to give this answer in a short while.
Thank you, sir. So the clinical outcomes of ablative techniques invariably correlates with the size of the kidney tumor rather than the technique employed. However, there are subtle differences in between these ablative techniques which can help us in choosing a single modality over the other. So RFA is a heat-based technique which is associated with shorter procedural time and lower bleeding risk because heat has got an inherent coagulant effect. It is also associated with heat sink phenomena, wherein the generated heat tends to decrease in the region where there is continuous liquid flow. So thereby making this modality a less suitable one when the lesion is located in the hilar or central perihilar region. Also, the increased impedance from generated heat tends to decrease the success rate when the diameter of the lesion increases to more than 3 centimeters in size. Cryoablation, on the other hand, is a cold-based technique with the advantage, as told before, advantage of real-time visualization of the ablation zone. It is less painful and can be used to ablate a much larger lesion as compared to RFA. However, it is associated with longer procedural time and it has high bleeding risk. Microwave ablation is another form of heat-based therapy with the shortest procedural time. However, microwave ablation reaches temperature which are much higher as compared to other heat-based technique. So this property is advantageous in one sense that a much larger lesion can be ablated within a short period of time, and on the other hand makes this modality a dangerous one when it is used for a centrally located hilar or perihilar tumor because the thermal damage can cause calyceal system as well as ureteric strictures. So unfortunately for radiofrequency ablation, no RCTs have been done till date. Whatever data we have is from retrospective observational studies, and these studies have consistently shown that the recurrence-free survival for 5 years and 10 years reaches 96 and 93%. Even in salvage setting, RFA reaches a success rate of 83% at follow-up of 4 years. However, when the tumor size increases, the disease-free survival drops down to 74% as compared to 90%. So this was a systematic review and meta-analysis published in 2022. It studied the long-term outcomes of RFA versus partial nephrectomy for clinical T1 tumors. It included 7 studies with 1,635 patients with at least 5 years of follow-up. So they found out that there was no significant difference between RFA and partial nephrectomy in terms of cancer recurrence, progression-free survival, cancer-specific survival, and major complications. This was another paper which was published this year only, which studied the perioperative and oncological outcomes of RFA versus partial nephrectomy for clinical T1A tumors. So the oncological outcomes were similar across the two groups. However, RFA was associated with significantly shorter procedural length, hospital stay, blood loss, and need for analgesia as compared to partial nephrectomy. So this paper by Waugh et al. Was one of the largest series published which studied the outcome of RFA in 200 renal tumors. They found out that the complication range from 9 to 27%, and the major complication includes ureteric stricture, acute tubular necrosis, calyceal cutaneous fistulas, renal abscesses. And most of these complications occurred when RFA was used for a hilar tumor. The minor complication includes the cell-limiting subcapsular hematoma. Moving on to the cryoablation outcomes, for cryoablation also we don't have any RCT. The data from observational studies have shown that the recurrence-free survival and the cancer-specific survival varies between 95 to 100%, and most of the recurrence occurs within the first 2 years of follow-up, and the metastatic progression range from 1 to 4%. So this was a systematic review and meta-analysis published this year, which studied the clinical and oncological outcomes following cryoablation versus partial nephrectomy for clinical T1 renal tumors. So it included 14 studies with 6,487 patients. So they showed that the rate of complication was significantly lower in patients who underwent percutaneous cryoablation as compared to partial nephrectomy. And in terms of oncological outcomes, there was no significant difference in local recurrence-free survival, metastasis-free survival, and cancer-specific survival when only clinical T1A tumors were analyzed. However, the overall survival tilted highly in favor of partial nephrectomy. And this can be explained because most of the patients who underwent cryoablation must be having much higher probabilities and poor performance. This was another systematic review and meta-analysis which compared RFA versus cryoablation for T1 renal tumors. It included 10 studies with 2,367 patients. They found that there was no significant difference in terms of complication, technical efficacy rate, change in serum creatinine level, and 5-year survival rate. However, the local recurrence rate favored cryoablation over RFA. But when the subgroup analysis was done, it was found when only clinical T1A tumors are analyzed, there is no significant difference. It is only when the clinical T1B tumors were included in the analysis, the recurrence-free rate favored cryoablation over RFA. This was another paper which studied the complication following 573 percutaneous RFA and cryoablation. So they found that there was negligible difference in terms of oncological outcomes. The complication rate ranged from 3.5 to 5%. With cryoablation, the specific complications were bleeding and hematuria, and for radiofrequency ablation, nerve injury and urothelial injury were the most common. Particularly the genitofemoral nerve and the femoral cutaneous nerve were involved in the nerve injury because of the heating of the iliopsoas muscle. For microwave ablation, the studies have shown that the recurrence-free survival reaches 93.3%, and in a retrospective propensity matched analysis between microwave ablation and partial nephrectomy, no significant difference was found in local tumor progression, cancer-specific survival, and metastasis rate. This is the only RCT which has been published for ablative techniques which compared microwave ablation versus partial nephrectomy. They found that there was no difference in the recurrence-free survival, hospitalization time, or change in estimated GFR between these two modalities. However, microwave ablation was associated with significantly less blood loss, complication rate, and decline in postoperative renal function. If we see the cost comparison, the nephron sparing surgery may anywhere cost 2.5 to 5 lakhs depending upon the city to city. The cryoablation cost in our country range from 1 to 2 lakhs, and similarly for RFA also, the treatment cost is around 1 to 2 lakhs. So now can we have the answer for the question raised earlier?
I think we left the house with these questions. So probably the answer probably is yes, these options are definitely there based both on evidence as well as practice. We don't have these resources, that is the other issue. We don't have expertise, that is the other concern. We need to refer, if we talk about procedure time, so definitely microwave has the shortest, and then RF and then cryo. If we talk about bleeding, RF has an edge over cryo. If we talk about larger lesions more than 4 centimeter, cryo has an edge over RF. If we talk about hilar lesions, cryo and definitely have an edge over RF and microwave due to heat sink. So I think keeping this in mind, if we know this indication, at least the referral will be important. and we can refer a patient and take a consultation with our supporting team, and maybe a informed shared decision can be made with the patient of these SRM patients. Thank you so much.
I have in fact, sorry, okay. Regarding RF, we had 2 cases experience, that's all, nothing more than that. But both the cases, we were not confident in doing blindly on a CT guidance. So what we did is we did a diagnostic laparoscopy, mobilized the fat there, and under vision, we passed that needle and monitored by a ultrasound from there. So the ultrasound should create a vacuolation, that bubbles should come all around. Where is the maximum site of the spread is there, that will be bubbling. So that will show you whether you are inside the tumor or completely it is taken care of or not. I think that was...
In fact, there are...
No, that's exactly. We had this, both the patients had solitary kidney and 4 tumors. 3 in 1 and 4 in 1. So in which case what we did was when one patient, in fact I think I presented in Tata one day, we did a enucleation of both the tumors above and we did an RF of the mid-polar tumor. So that same patient underwent a radical nephrectomy on the other side. The second patient was a solitary kidney with another 2 or 3 tumors wherein we did a RF independently.
These were inoperable tumors, sir, because
It's not the question. We were not confident to do. It's nothing like inoperable, it can be, but the only thing is all were solitary kidneys, so we were not really confident.
Have you seen more than the T stage, have you seen the histology of these tumors, how the response is? Because SBRT was showing that clear cell RCC has got some role. Likewise, have they seen, other than the size of the tumor, the histology of the tumor response to the mobility?
The treatment outcome doesn't depend on the histology because it is just heat-based or cold-based technology that destroys the cell in the particular region. So whatever studies I have quoted and we have gone across, there is no correlation with the histological type.
And moreover, the follow-up we have clearly, what evidence we have shared is that follow-up is, there is debatable concern about the biopsy post-procedure to say whether there is something left behind or not. So probably the follow-up is primarily based on the imaging and seeing the non-enhancement as the criteria and the shrinkage of the tumor in due course of time. And regarding the approach, what Malik sir was asking, probably sir, any approach is definitely, if you use percutaneous open lab, it depends upon whether that area is properly covered that by the probe or not.
First thing.
And RF per se, it's not very difficult to monitor the thing, what we are doing. We can just place the probe. Cryo is best monitored by seeing it. RF is difficult to monitor.
RF is, you need an ultrasound to show the vacuolation coming on the periphery of the rim of the thing. You see, the thing fan opens up and it gives you a particular shape, around 2 centimeters is the diameter if I remember correctly, which gives, and that globe of the thing will become ablated. And in the periphery you'll see that vacuolation with hyperechoic shadow coming up on an ultrasound. But the problem here is we need to be sure that we may need to attempt once more after 3 months if there is an enhancement happening on the CT scan. So 3 months to 4 months is the time when you do a CT scan. If there is an enhancement, we may need to repeat it.
People have started doing CT scan immediately after the ablation procedure so that if it is needed, it can be done in the same setting.
Immediately after ablation is not a great idea. There is one paper by I think Marburger, I'm not sure, where they did RF for about certain cases and then the partial nephrectomy later. All the 2 cases had a viable tumor inside. So talking about RF as a sole modality without follow-up is probably will not be right.
Thank you very much, all my chairpersons and the speakers. Now I would like to invite my new team of chairpersons, Dr. Shivaji Basu, Dr. Premnath Dogra, Dr. Rishi Nair, Dr. Nirmal TJ, Dr. Sambit Mohanty, and Dr. Vidur Bhalla. The next topic would be now SBRT in small renal masses, which would be presented by Dr. Ankit Mishra and myself.
So a very good evening to the chairpersons, faculties and delegates. I am Dr. Ankit, and along with Dr. Anuj here, I'll be talking about SBRT in small renal masses. So, what is the common thing between these three pictures? One is the saber of Tipu Sultan, the other is the saber shot of Roger Federer, and the other is the saber which is an equipment in the radiation oncologist's purview. So it stands for stereotactic ablative radiotherapy. Upfront disclosure, we are both urologists by training, so pardon and apologies for our limited knowledge of radiation technology, but we'll try to understand this technique from the urologist point of view. As we all know, renal cell carcinoma is not uncommon with an incidence of 0.33 million per year, and the incidence that has been continuously been on the increasing trend. In the last decade, it has increased at 0.7% per year. The reason being increase in the life expectancy, greater use of imaging studies, more accessibility to clinics and insurance schemes. The median age of this cancer is 65 years. The greatest increase has been seen in patients older than 70, and many of them have their other comorbidities. So SBRT or SABR, SABR, it stands for stereotactic body radiation therapy. It delivers a very high focused radiation dose for a very short period of time to a particular organ, and this condenses the total radiation course. Only 1 to 5 visits would be required instead of multiple weeks. It is non-invasive and it can act as an alternative option for therapy. What are all the tools that are required for this therapy? First is the conviction and the convincing ability. The other would be a linear accelerator with image-guided radiation therapy, which can give a dosage of 40 to 50 grays in 3 to 5 fractions, and physics support. The questions that we would be looking forward to answer today from the point of view of radiation oncologist would be, what is the local control of this therapy? Is it really safe? Can we pull it off with a standard linear accelerator? What is the best fractionation? What are the issues to deal with, like motion management, planning and contouring? From the uro-oncologist point of view, these would be the patient is not opting for surgery, so why not offer an RFA or a thermal ablation? Can we really do an SBRT in a single kidney? And even if the tumor is more than 4 centimeter, how do we follow these patients up? What happens to the GFR in the long run? And do we biopsy to prove the local control? Now conventionally, RT doesn't work in RCC. So why we say this is that previous studies in the 1970 eras, comparing the pre-op radiation and post-op radiation, they showed that it was not very improving in the overall survival. In fact, it proved to be detrimental also in some cases. But the problem with these studies were they studied the conventional fractionated doses, which were 30 gray given over 15 fractions. The other obvious problem was that the exposure of the other body parts to the radiation, and so the radiation in this early era was associated with high rates of complication. However, there was a meta-analysis which was done, which showed that post-operative radiation therapy definitely reduces the loco-regional recurrence with acceptable GI toxicity if modern techniques like 3D imaging, conformational radiation therapy, and IMRT are included together, even in patients with high risk. So there is a need to run a multi-institutional trial to see the additional benefit and just not remove the RT from the options. The other studies are there which show that the human tumors which are radio-responsive, they have a direct correlation with the slope of cell survival curve. And there are certain cell lines like CAKI1 and A498, which have been shown to exponential decrease in growth when they were exposed to higher grays per fraction. That was a cutoff of 6 gray. So how does stereoablation overcomes the radio resistance? In this pathway, we see that the conventional fractionated doses, which were around 1.8 to 3 gray per fraction, they usually act on the tumor cells and create a hypoxic environment which leads to activation of HIF1 alpha and promotes the VEGF factors, which maintain the endothelial lining and are responsible for the radioresistance. However, a single dose radiation, more than 6 gray per fraction, it causes a direct damage to the tumor cell as well as the endothelial lining by converting the sphingomyelin to ceramide, which causes endothelial apoptosis, and this is responsible for the radioresponsiveness when a high dose of radiation is given to kidney. So again, this shows the same thing, the same pathway, and when we give a single dose radiation of more than 8 gray, there is endothelial apoptosis and tumor response is there. So in a way, we can compare the conventional radiation with just raindrops falling from the sky and ablative radiation as just a flood for a short period of time. So summarizing the switch, why moving towards a stereotactive radiation therapy is because of the improved diagnostic imaging, thin slices of CT scans being available, patient immobilization techniques like backlog and body bag, and newer techniques of IGRT, IMRT, image guidance, motion management, along with this leverage of biology of this pathway of conversion of sphingomyelin to ceramide, endothelial apoptosis, resistance to hypoxia, and the abscopal effect of immune response, which causes anti-tumor effects in these patients. So this all challenge the conventional wisdom that RT does not work in RCC. So I would invite Dr. Anush to take the discussion further.
Thank you, Dr. Ankit. So with the concept in mind that the previously understood concept about radiotherapy, that it is not, it's a radio-resistant tumor, has now been changed by giving more dosage in lesser fractionation. We come back to this concept of what is the role of radiotherapy in small renal masses. So the previous, we only have some very restricted data that we are dealing with, but the best meta-analysis that we have in our hand is of the 2016 IROC analysis. So this was majorly done by Peter McCallum Karolinska, and it was a consensus statement from the International Radiosurgical Oncology Consortium for kidney for primary renal cell carcinoma. So this is an exhaustive summary which we are dealing with, and as we had seen for the various ablative therapies, we still have the same criteria of patient selection. So the consensus statement covered the various aspects, including treatment technique, the patient follow-up, medically inoperable and patients who are at risk of dialysis or patients who are not willing for surgery are the prime candidates that we should think about for giving this option. Both small and large tumors. This is an important differentiation that is there compared to what other thermoablative techniques we have, that even now there is an emerging data that we can use these SABR techniques for larger tumors too. Along with that, the follow-up should be there. So the follow-up in this is keeping in mind the concept that the tumor is having a very longer course in terms of its resolution. So this is just to give you an idea about how it is planned. So this is a very technical aspect compared to what we should be understanding as urologists. So as we can see, the innermost is the red zone or the target zone. And subsequently in concentric circles, we go along, and this is the area that we target for our radiotherapy. So this is how it looks. The treatment is in the neon blue area. This is where the radiation is going from all the directions. And then we have a very steep dose gradient, and immediately adjacent organs are untouched. So these all things are there. So we go back to that IMROC analysis, what kind of patients we were dealing with. So the median age was 73.6, and medically inoperable were most of these patients. So 96 patients, which was almost 75%. All these patients, most of these patients had a biopsy which was done, so which is also recommended in this study. The maximum dimension, as we can see, 4.2. So it was covering both the small renal masses as well as the larger ones. And many of the patients, so almost 1/3 of the patients were having a solitary kidney with a BED 10, a median of 87.5 gray. Now this is very characteristic. So this is what is called as a biological equivalent dose. So the amount of grays or the amount of radiation that you are giving in 20 fractions, you cannot compare the same amount of gray which you are giving in hypofraction. So the BED is the most important thing, and subsequently we'll also know that this is one kind of a limitation in this study. So the BED ideally in these cases should be more than 100 grays. So this was the follow-up that we all saw, that it was 92% of cancer specific survival was there at 5 years.
The local failure was almost 5.5% and the distant failure was around 10.8%. So this was a follow-up of almost 190 patients on a 5-year. Again, if we go into the sub-analysis, so in solitary kidneys, how does it perform? So when the median tumor diameter was of 3.7 centimeters, with a mostly more than 4 centimeters were approximately 37%, the mean eGFR decrease, which is of the prime importance, was around 5.8 plus minus 10.8 ml per minute in solitary kidneys. And the dose of the fractionation was 25 grays. So in solitary kidneys also, these patients, there was a decrease in GFR, but not all these patients landed up into dialysis. As was also covered in the previous studies, the various RFA, the cryoablation, and the microwave ablation, as shown by Dr. Ankur, that the wheel which was there, the taraju which was there. So if we put an SABR with all these techniques, we would say that it won't require any general anesthesia as it is required in the surgery. It is very much important that it is also good for the perihilar tumors. Large tumors, there is a restricted data, but even in large tumors, we can use the stereotactic ablation techniques and also in the non-invasive ones. So this is how, again, we can see that in concentric neon area, this is the one which is being targeted in the IGRT technique, and subsequent follow-ups, we have an important response rate. So as it is shown, it is slow but a continuous response. So a slight informal thing, once I was given this topic of SABR, I searched it on the net. So the first thing which came was an Arabic word, sabr. So I think the follow-up needs some sabr or some kind of a patience, because these patients, they take a longer response rate compared to what we see as surgeons in terms of our partial nephrectomies. So as we see that the response rate comes till 3 years. So many patients who might not be showing a good response rate might have to actually be seen after 3 or the 5 years. Also, if we see in terms of the GFR, the actual or the mean decline was around 13.5. So an ideal kind of a recommendation is that we should have a good GFR of these patients, approximately 60 ml per minute, so that we can use these techniques. So what is the right patient that can fit in? We don't have a very definitive guideline. There are no EAU or NCCN guidelines which strongly recommend this therapy. But yeah, we can see such patients in our OPD and decide if we can give a shot of radiotherapy. So these can be medically inoperable, early stage primary RCC, patients who are not opting for surgery. These are too big, unsuitable for RFA or NSS. Any patients with single kidney, incidentally detected as synchronous or metachronous cancers, and with the philosophy of an abscopal effect, that by giving radiation, we can also tackle some other kind of malignancy which is there, we can use this technique. So in terms of the tips, and this is a little technical aspect, we need to see a GFR and biopsy before the surgery. The important point is that in these cases, the respiration rate might alter the tumor target. So we have to see in terms of what kind of slice thickness we need. We need a FFF, which is a free flat filtration. So whenever we are doing a 4D CT in these patients, we target the tumor, and with respiration, we try to achieve the same response. So tumor visualization with high precision planning and delivery, a robust image guidance with a quick delivery, and intrafraction motion management is needed in these cases. Cybernet system for SBRT is the one which helps us in, improving these outcomes of respiration that we can do. Another very important concern is that kidney is deep down inside the abdomen, so there can be a local toxicity, but with these latest techniques and PRV, we can improve our target and do lesser damage to the surrounding organs. So again, this data of the IMROC, it showed that by giving hypofractions and a more dosage would be little more better than the hyperfractionation. So in the coming times, we are kind of combining these studies with immune checkpoint inhibitors, and these results of Samurai, Cytoshrink, and Raster are still pending. So the take-home message is that SBRT to primary RCC is a real option in clinical practice. With the coming Australian guidelines and subsequently, this will be a viable option in present future. Post-SBRT responses are slow and steady, and hence a sabr. And post-SBRT GFR drop is 10 to 15 ml minutes over long term. So this is our Uro-Oncology division of surgical radiation and medical onco at TMH. And I would just use a small short opportunity of inviting you everyone at our Homi Baba Cancer Conclave. This is our first conference that we are holding in this August. Thank you so much.
Well, thank you, Dr. Anuj and Dr. Gagan. For a short while, I think we have to go to OT, Dr. Pranjal Modi. He is waiting, I think, important steps. Can we connect us to the OT, please?
Pranjal sir,
Yes.
your mic on sir.
Yeah, so just we are going to apply the bulldog. So,
Yes, Dr. Pranjal, very nice. We have been watching you very silently, and although we had some here lectures. So we like to know now what is your plan. This seems to be an endophytic tumor, and you have demarcated with the help of the drop-in ultrasound.
yes, sir, we have done with the help of ultrasound, we have marketed, but I'm not very sure, especially the anterior aspect. Posteriorly, it is clearly demarcated. I'll just put a one bulldog on a vein also.
Left.
Panoramic bar card.
The clamping vein, any specific reason? Pranjal sir?
Yeah, because I have seen it's too close to the hilum, and when we try to enucleate close to the hilum, we don't want so much of bleeding from the venous side also. So that's why.
That's why you did. That's why you did Doppler. We were seeing
Yes,
that.
yes, and even in a CT also it is very clearly seen. So maybe it is approaching to upper calyx. The tumor is clearly approaching the upper calyx. Let us see now how we can deal with this. Sister camera ऊंचो રાખજો સહેજ. Show me anteriorly अंदर रहीने अंदर जाओ जी. Yes, अंदर. Pneumo check karo.
Maybe your bulldog is not working, sir.
It's working. There is some amount of blood. It's likely to come. Bulldog on the vein is not probably completely applied. What is this? It's coming out. Irrigation je શું છે suction. Why it is producing such type of?
These bulldogs are not ferocious.
No, it's not bleeding. It's a.
After putting bulldogs, does anybody use a Doppler, Doppler to make sure there's no
Cautery
blood?
लगाओ. It's coming from this surface vein. जल्दी करिए.
We don't want to disturb you. Go ahead, please.
Yeah. Just a question to the house. After putting the bulldogs, does anybody do a check, ultrasound or Doppler to make sure that it just takes a few minutes? In case of complex tumors,
You know,
because you won't encounter problems like these.
Once you put the bulldog clamp, your heartbeat goes
It's
up.
very surprising to see
When
the
you are going
bleeding
to-
right
going
now.
towards it,
બહાર કાઢજે સહેજ અને અહીંયા ઊંચો રાખજે કેમેરા.
So going with the same question, recently what I have started doing is using the indocyanine green for this purpose, basically just to ensure that complete ischemia around the tumor has been achieved or not. Indocyanine does not require much of a time. You can give dye just before the start of surgery, and then it stays there, just tells you in just a click of a second whether the parenchyma is enhancing or not.
I think you're spending 2 minutes extra to make sure that, you've cut off the blood supply, will avoid the situation, and then you can do a surgery, a much better surgery.
We can continue with the lectures. Okay. As you desire. Oh, sure.
નજીક રહેજે હા નજીક રહેજે કહું છું સાહેબ જાતો નજીક જા નીચે રાખશે દબાવ મને દેખાતું નથી ક્યાં છે નીચે દબાવ ની બહાર કાઢ નીચે દબાવ તારા તરફથી હા ઓકે બહાર કાઢજે ક્યાં બતાવે છે સીઝર્સની ટીપ પર બતાવવાનું છે સ્યુચર તૈયાર છે ને ક્યાં બતાવે છે સીઝર્સને બતાવવાની છે નોટ ધ સક્શન સીઝર છે ને ભાગ સેન્ટરમાં રહેવો જોઈએ બહાર કાઢ ઉપર બતાવો અહીંયા બહાર કાઢશે calyx sorry it's my fault ગરમ પાણી તૈયાર ખવડાવજો It's okay, it doesn't matter. I don't bother about time. बाहर काढ़ो बाहर नहीं 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 अंदर एम नहीं चलो बाहर काढ़ से एक मिनट अंदर बाहर मीन्स के withdraw just tumor is to be okay clean the camera and give me the suture patapat ગેસ લીક થઈ જાય એવું કેવી રીતે પકડ બેન શું કરે છોડી કેમ દેજે ગરમ પાણી લાવ બીજા હાથમાં નીડલ ડ્રાઈવર બેન લેફ્ટ હેન્ડ નીડલ ડ્રાઈવર મેરીલેન્ડ ક્યાં કરવાનો અને આ છે ને ભાણિયાને છોડી દેવાનો અહીંયા મૂકી દેવાનો હા
Good evening, Dr. Pranjal.
તો બેન તમે મને રાઈટ નું આપ્યું you should be giving me the left needle driver left side નું needle driver બેન I have instructed it શું કરો છો તમે ઊંધું આપ્યું છે ઓકે ચલો suction first suction leave it check that suction is functioning mane garam okay now there must be a small clot over there okay just leave it garam pani aapko ek wakhat छोड़ो भाई न्यूमो लीक ना થાય ધ્યાન રાખ ગરમ પાણી નજીક લાવ અહીંયા લાવ અરે યાર છોડ દે okay just hold it there needle driver and needle ક્યાં જતી રહી બતાવો ભાઈ go પેલ છેક અંદર જતી રહે હા I must see બહાર કાઢ જશે બહાર કાઢ પેનોરામિક go in બહાર કાઢજે બહુ નજીક ના જઈશ બહાર કાઢ બહાર કાઢ go in છે ને એક મિનિટ આ પકડ દો આમ બતાવો આમ bar card. ઇમોલોક ક્લિપ રેડી બહાર કાઢો એટલું બધું નહીં.
Dr. Ravi, can we now go with the talk? If we go, people keep on watching his tutoring.
I just want to have a comment. Pranjal,
Yes.
my contention was if at all we have two clamps, one on the artery and another on the vein, and we still see some pulsatile bleeding coming from arterioles level, the first thing is let us take out the vein clamp. There will be some element of advantage to us. That's what I was wondering.
Okay.
You've done the job. I think we can go ahead with the remaining lectures, otherwise we will be behind schedule.
Okay, so moving ahead with the lecture session, I would like to invite Dr. Ketan and Dr. Ashish Khanna for their talk on lymph node management in RCC. So we'll be closing this session at 5:30. So both the speakers have 15 minutes, which comprises of 10 to 12 minutes of presentation and subsequent 5 minutes for discussion.
Good afternoon, everybody. I am Dr. Ashish Khanna from the Rajiv Gandhi Cancer Institute in Delhi, and I have alongside with me Dr.
Ketan Mehra. I am Assistant Professor Urology at AIIMS Bhopal.
Over the next 10 to 15 minutes, we are going to discuss about the management of lymph nodes in renal cell carcinoma. So whenever we are going to discuss about the utility of lymph node dissection, we have to see various facets of this procedure, namely its staging utility, its prognostic significance, as well as any therapeutic significance that it may have.
Coming to the staging of the lymph nodes can be done by two methods. First is imaging modality and second is by surgical method. In imaging modalities, as you can see, the computed tomography and MRI, these two can even miss small lymph nodes that are less than 1 centimeter. And another fallacy is if the lymph nodes are more than 1 centimeter, there are 58% chances of having reactive hyperplasia. On the other hand, the functional scan, that is FDG PET scan, can diagnose even the smaller lymph nodes which are positive.
So the other method, which is the gold standard to detect the involvement of a lymph node pathologically, is surgical staging, whereby you do the surgical excision of the lymph node followed by histopathological examination. An important caveat here is that in addition to the conventional H&E stain, it is imperative that you perform a immunohistochemistry of the lymph node so as not to miss any micrometastasis that can be missed.
The lymph nodes dissection can be used for prognostication. It is very, very helpful in prognosticating the disease, the RCC. This is the primary study by Robson et al., which showed about that lymph node dissection is very much helpful in prognostication, and it shows that if lymph nodes are positive, it has a very poor prognosis in the disease. As we can see that the overall survival in lymph node positive disease, for 1 year it is 68%, for 5 years the overall survival becomes 28%, and the 10-year overall survival is 18%. That shows that prognostic role, the positive lymph nodes has a very dismal prognosis.
Other studies have also shown that even in patients who have a primary disease which is T1 or T2, the presence of pathological nodal disease makes the prognosis even worse than a patient who has locally advanced primary tumor in the form of T3 or T4 in the absence of any nodal disease. And this is reflected in all outcomes, oncological outcomes, be it metastasis-free survival, recurrence-free survival, overall survival, or cancer-specific survival. Also, for a given T stage, the presence of nodal metastasis confers a poor or a dismal prognosis. And this lymph nodal positivity has highest prognostic value for a low stage or low grade disease. For that I mean, suppose a patient has a nodal involvement in T1 stage, the chances of a patient dying due to cancer become 6-fold as compared to a patient who has nodal involvement for T4 disease,
where the contribution of dismal prognosis by the nodal involvement is lesser.
Now coming the therapeutic utility, which is the Achilles heel, there are various studies which shows that there are no benefit of lymph node dissection in RCCs. However, there are some studies which shows that there could be some benefit doing lymph node dissection in RCCs. That means there are various studies with different results.
The only prospective randomized trial in this regard is the EORTC 30881. It is a randomized trial where they have randomized the patients into two groups, radical nephrectomy alone versus radical nephrectomy with a lymph node dissection. Of the 346 patients who underwent lymph node dissection with radical nephrectomy, the nodal positivity was only 4%, and the study concluded that there is no oncological benefit of performance of a lymph node dissection. Critical appraisal of the article reveals that 75% of the patients in this study who underwent lymph node dissection had T1 or T2 disease, where itself the involvement of lymph nodes is very less. In addition to this, the template of lymph node dissection was not specified by the authors.
Now, why the lymph node dissection in RCC does not have any therapeutic benefit? So, the first of all, the lymphatic drainage of kidney is very, very different. We cannot predict the lymphatic drainage, and hence we cannot predict the lymphatic dissemination also. There is no any standard template for lymphatic dissection which is being practiced by anybody. And the factors that predict the lymph node metastasis are the same factors which also predict the systemic disease, the metastasis in elsewhere. So there are always, not always, there are associated, there could be associated occult systemic disease in patients which have lymph node positive disease.
Now, discussing these points in detail, we said that the lymphatic drainage of RCC is complex and unpredictable, and it is seen that in almost 46%, so almost in half of the patients, there will be skip metastasis to the para-aortic or the paracaval lymph node without involvement of a hilar lymph node. On the other hand, almost 1/3 of these patients will not drain into the regional lymph nodes and may have direct connections to the thoracic duct. The theory that the nodal disease may be associated with occult systemic disease is on the basis of observation of various studies, where they have seen that after radical nephrectomy and lymph node dissection, patients of node positive disease were followed. Majority of the patients have recurrences, but these recurrences are in most cases multi-organ metastasis, and in only isolated cases are these retroperitoneal recurrences. Similarly, in this study by the Mayo Clinic, they saw that out of the 138 patients with isolated nodal involvement at the time of radical nephrectomy, 108 patients recurred, with majority of them recurring in systematically. So they concluded that in patients in whom clinical as well as pathological examination at diagnosis reveals isolated nodal disease in the absence of overt metastasis, there is some component of occult systemic disease that always persists. In addition, we have noted that multiple studies have varying lymph node dissection templates, which makes the interpretation of all the data very difficult.
As told by Dr. Ashish, there could be therapeutic benefit also in lymph node dissection. So there are two observations which shows that there was some therapeutic benefit in lymph node dissection. However, it was associated that in patients in whom we have benefit, those patients should have extensive lymph node dissection along with at least less than two or less than two lymph nodes positive, as compared to the patients in which there was limited lymph node dissection. So, in nearly all patients who were free of progression for 5 years, there was disease-free further also. So, this is also one of the factors.
So, what Dr. Ketan is trying to point is that there is a small subset of patients of renal cell carcinoma with limited nodal positivity who may benefit and continue to have durable responses even after lymph node dissection. However, at present, our ability to identify such patients is limited. So now we have discussed that the lymph node dissection has a staging and prognostic capability. In patients who have nodal disease, you may opt to do surveillance more aggressively, and they may help you select these patients for adjuvant therapy, especially in the form of pembrolizumab. But now the question arises in whom you should offer lymph node dissection, and the question is answered by the guidelines presently, that it should be offered in patients who have clinically enlarged lymph nodes, as well as in those patients in which the primary tumor characteristics makes the patient a high-risk candidate for lymph node involvement.
Now, in whom we should go for lymph node dissection. So this is the criteria by Blue et al., in which they have mentioned some features like nuclear grade, sarcoidoid component, tumor that is more than 10 centimeter, primary tumor stage that is PT3 and PT4, and histological tumor necrosis. So if any of the factors, if two factors are positive, lymph node dissection can be contemplated in the patient.
Crispin et al. Used the same criteria and identified 169 patients of high-risk renal cell carcinoma. The percentage of lymph node involvement was 38%, and interestingly, these factors of the primary tumor are identified by intraoperative frozen section. Another important aspect of this paper was they had done bilateral retroperitoneal lymph node dissection and identified the recommendations for surgical template. They found that in these 64 patients with lymph nodal involvement, 45% of these patients do not have hilar lymph node involvement, and therefore if you just resect the hilar lymph nodes, it is a limited value dissection. They also found that for right-sided cancers, there is no isolated para-aortic lymph node involvement, and similarly for left side, there is no isolated para-caval involvement. What they are trying to say is that the template of dissection should be an ipsilateral extended lymph node template, extending along the ipsilateral vessel and also including the inter-aortocaval groove.
Now, how many lymph nodes should be considered the optimum? So there is one study, you can see that by Teron et al. It shows that if the lymph node numbers that we are dissecting are more than 13, then the positivity rate also goes up, that is 20%. And if the lymph nodes number are less than 13, the positivity rate becomes almost half, that is almost 10%.
So what we are trying to convey is that extended lymph node dissection is the template to follow, and a minimum lymph node yield of 13 is expected to be indicative of a good dissection. So finally, coming on to the take-home messages for our talk, lymph node dissection has definitive staging and prognostic benefit. The therapeutic benefit for lymph node dissection is still controversial, although there may be a subset of patients with limited nodal disease who may continue to experience durable responses. High-risk factors as elucidated by Blue et al. Can be considered for performing lymph node dissection, and extended unilateral template is the way to go if one chooses to perform the lymph node dissection. Thank you.
Thank you.
Well, thank you, Dr. Ashish and Ketan. You have done nice dissection of the literature. What ultimately where we have reached, if I remember of my residency day, I still remember in Campbell edition 3, but you mentioned in the first line, the same thing was written, that lymph node dissection will certainly stage the disease and you can prognosticate, nothing beyond that. And I believe we are still there at the same stage after 40 years.
Yeah, true, sir.
So, as you mentioned, the lymph node drainage of the kidney is very capricious, is very not defined. That may be another reason that we don't know the true template, what should be the template. Then you mentioned directly going to the thoracic duct, some of the lymphatic bypassing, all those areas. So there are certain things still we need to know, I think. But as of today, where we stand, very nice that you have done the literature review and presented. Thank you.
Thank you. Thank you, sir.
Just one more question. There is an inherent contradiction when you on one hand say that when there is a lymph node metastasis present on imaging, there is a very high likelihood that there is a systemic metastasis present. And on the other hand, you suggest that doing lymphadenectomy in these cases can have a therapeutic benefit. So I would like you to elaborate a little bit more on that.
So that study where we said that patients with limited nodal positivity on an extended template, that means if you have dissected the retroperitoneum, you have got 13, 18 lymph nodes, and then you get up to 1 or 2 lymph nodes, these patients are actually having limited nodal disease, and such patients may have durable response. On the other hand, in the same study, if a limited template was done and about 4 lymph nodes were taken out and 2 were positive, and you treat them in the same way, they perform worse as compared to these patients.
No, so this is based on the frozen section of the...
No, sir. This is final histopathological examination. What I mean to say is that adequately done lymph node dissection, if it reveals a limited disease.
No, so does that mean you should be doing template extended lymph node dissection in everybody?
Yes, sir, that is what we have suggested.
That is the particular study,
That
sir.
in patients who have high risk criteria for lymph node involvement, the way to go if we are choosing to do a lymph node is an extended.
Should it be done in clinically node positive patients or clinically node negative patients who've got high risk features on the primary?
So for clinically node
That's where if you do a good dissection, you may be able to clear off the micrometastatic disease, and that may have some therapeutic, I mean, there's no RCT on it.
Yes, yes.
You know, and there never will be, because we are all doing, minimally invasive surgery. Nobody has the time to do, RP-LENDs and all that.
I think
that's
you are given
core
the
issue.
message, whether you do limited or extended, you are at the same point where you are started, and you may have to look up to immunotherapy or immune checkpoint inhibitor. That may be the option next, whatever is your limit of the dissection. Thank you very much.
So Ashish, even I got confused. Let's say there's a right-sided tumor which has got all high-risk features, but clinically there are no nodes. Now you know that the template for a right-sided tumor is also the interaortocaval groove. So that patient comes to me, I take out his right-sided tumor, I remove the gerota, everything, lay bare the IVC. Do you want me to go into the interaortocaval groove and do a lymph node dissection?
So the guidelines and the literature suggest that just doing a hilar dissection, doing a radical nephrectomy with hilar lymph node dissection is of no use. If you are choosing to search for lymph node involvement, for that you need to do a good template dissection, and according to the guidelines at the moment, by mapping studies, it is advisable that you do the paracaval, retrocaval, interaortocaval lymph node dissection.
But don't forget that you are increasing the morbidity.
Should be done under a study protocol, not in routine clinical practice.
Otherwise, you're just
that
doing,
is what I wanted to.
Because by doing this type of extended lymph node dissection, certainly the morbidity will increase.
Yes.
You should keep in mind, you are not adding anything to a patient benefit, but you are giving downside.
So again, this statement is a little controversial. The EORTC trial 30881 categorically says that there was no difference in the complication rates, although there are studies, definitely the incidence of chylous ascites, vascular injuries, lumbar vessel bleeding, obviously these will occur, but in expert hands, I think the complications may be balanced.
What was the year of this study?
Sorry, sir?
Which year this study was
The
done?
study started in 1989, and then they had completed 30 years, so if I'm not wrong,
At that time, there was no CT scan, MRI scans, PET scans, nothing. Only.
There was CT scans.
No, I mean, not that Ross. This is a 30-year-old study.
Yes, sir. But CT was definitely there, sir. That time.
Thank you very much. Now coming to the last lecture on this session, I would like to invite Dr. Avni Tiwari and Dr. Shrutish Sabnis for the talk on importance of pathology in management of small renal masses.
Good evening, everyone. I'm Dr. Avni Tiwari from Regional Cancer Center, Raipur. And with me is
I'm Dr. Shruti Sabnis from MPOH Nadiyar.
So we'll be talking about the importance of pathology in management of small renal masses. There is an increasing incidence of renal cell carcinoma in last few decades. And small renal masses are defined as solid or cystic enhancing kidney tumors or lesions which are less than or equal to 4 centimeters in size and which corresponds to the PT1A of TNM staging. They are usually incidentally detected, and this is attributed mainly to the liberal use of abdominal ultrasound or abdominal sonography these days. And as we all know, not all small renal masses are malignant, but those which are, they have heterogeneous features, and significant proportion of them are considered to be of low malignant potential. Although there is increase in incidence of small renal masses, mortality has not increased proportionately, and this can be attributed to the fact that 20 to 30% of these lesions are benign and they have an indolent course. So now there is an increasing concern about the morbidities of the treatment of potentially indolent lesions. Understanding the biological behavior through histomorphology shows improved prediction of the local tumor growth or stage progression and their metastatic potential. Whenever there is ambiguous clinico-radiological correlation, and now there is an absence of special biomarkers for it, the best method to characterize small renal masses is a renal tumor biopsy. Now, the role of pathologist is at pre-operative, intra-operative, or at the post-operative levels. So now the indications for pre-treatment renal tumor biopsies. So all small renal masses should be considered for biopsies when the results may alter the management of the tumor, and it should be considered when the mass is suggestive of any lymphoma or any inflammatory lesion. It should also be performed before the thermoablation for the diagnosis and after ablation to guide the surveillance. It is contraindicated predominantly in the cystic masses and the renal masses which are originating near the collecting system. Also, in frail or older patients where the management will not be changed after the biopsy, it shouldn't be performed. Now coming to how biopsy helps in management. Now as soon as we see the biopsy, we have to consider whether the lesion is neoplastic or non-neoplastic. First should be the difference between, to find out whether it's a neoplastic lesion or not. So we have a differential diagnosis of abscess or localized xanthogranulomatous pyelonephritis or tuberculosis. All these presents as small renal mass, but diagnosing these will completely alter the management. Now if the lesion is neoplastic, we have to find out whether it is a benign or a malignant lesion, because benign lesions again like fat poor angiomyolipomas or oncocytomas or metanephric tumors, diagnosing these will also alter the management of the patient. If malignant, we have to see whether they are renal cell carcinomas or not, because if they are not renal cell carcinomas, they can be hematolymphoid malignancies, which also present as small renal masses or metastasis from other tumors. So in these cases, the treatment depends upon the primary lesion. Now, if the tumor is RCC, what we see, we look at the biopsy and we identify what is the morphological subtype of the tumor. So basically, there are three main morphological subtypes. One is clear cell subtype, another is a papillary subtype, and third is a chromophobe subtype. But it is not always easy to differentiate all these three entities as separate ones. We have a clear cell variant of clear cell RCC, which is a very aggressive tumor. But there are tumors which have overlapping features and they are showing clear cell morphology. And many of them are having a very good prognosis. Then we have a non-clear cell papillary pattern or papillary RCCs. Again, this is also a part of a mixed morphology tumors, and we have a list of tumors which are presenting as a papillary pattern, but they have a better prognosis. Again, the third pattern is a chromophobe type, which is also again intermediate prognosis tumors, and these are the list of tumors which are having intermediate prognosis, plus they have a chromophobe type of morphology. So now we know that there are various morphological features which are overlapping, and it is very difficult to diagnose it on a small renal biopsy. If there are intermixed features of clear cell or papillary or chromophobe type, then